Imagine you're gearing up for something big, maybe even major surgery. All the medical info coming at you can feel like a bit of a tidal wave, can it? What if there was a way to, cut through that noise, get right to the heart of what really matters for a good recovery?
Well, that's exactly what we're doing today. Welcome to the Deep Dive. We're jumping into enhanced recovery after surgery, ERAS guidelines. Specifically, the brand new 2025 recommendations for elective colorectal surgery. And these aren't just dry documents. They're really the most up-to-date, evidence-based roadmap out there, designed to significantly improve how patients do.
Right, and what's really interesting about the source for this deep dive is just how fresh it is and how rigorous. We're talking the newly released 2025 ERA Society recommendations, a proper de novo guideline, you said, so built from scratch.
Exactly. Not just tweaking the old ones, built from the ground up. And the methodology behind it is, well, incredibly robust.
So our mission for you, the listener, today
is to really unpack these guidelines. We want to pull out the most impactful stuff, the surprising changes from before, and crucially, the why behind them. Think of this as your shortcut, to get properly informed on the cutting edge of surgical recovery.
Okay, let's start right at the beginning then. For someone maybe hearing ERS, but not totally sure what it involves, why is it such a big deal in surgery?
Right. So ERAS, at its core, it's a multimodal pathway. That means lots of different things working together. And it's all evidence-based. The whole idea is to reduce the stress of surgery on your body, keep things functioning as normally as possible, and just speed up recovery. Since the first guidelines back in 2005, the benefits are really proven. Fewer complications, faster recovery, shorter time in hospital, even lower cost for major colorectal surgery.
And this is the 5th edition you mentioned.
That's right, the 5th, which just shows how it's constantly evolving, always taking in the latest research.
I really like that idea, minimizing stress on the body. It just sounds, well, better for everyone involved. You mentioned the incredibly robust methodology. What does that actually mean? How did they arrive at these recommendations?
It means they didn't just glance at a few studies. They put together an 18-member group. Surgeons, nurses, anesthesiologists, crucially, experts in epidemiology and stats too. They structured every single question using frameworks like PO population, intervention, comparator, outcome to make sure they were comparing like with like. Then they systematically searched through mountains of research, PubMed, Embase, Cochrane, right up through late 2024 to get the absolute latest data.
So really digging deep into the evidence.
Absolutely. And they didn't just count studies. They used systems like GRADE. It's a grading of recommendations, assessment, development, and evaluation to assess the quality of that evidence. High, moderate, low, very low. That helps decide if a recommendation is strong, you really should do this, or weak, maybe consider doing this. And finally, they use something called the Delphi method. Basically getting all those experts to agree, needing over 70% consensus for each point.
Wow, that's some serious legwork. So, okay, bring it down to the patient level. For someone having colorectal surgery today, what does all this mean for their experience?
What it means for you is that these guidelines look at everything that might impact your outcome, big or small. And the consistent message, really, is that the more closely the whole ERAS plan is followed, the better the short-term results. And there's growing evidence it might even help with long-term survival, too. It's a truly comprehensive, holistic approach.
Okay, let's walk through the journey then. It starts way before the hospital, right? That's where it gets really interesting, what can be done before you even get near an operating room.
The first step is actually pretty powerful. Pre-admission education and information. It's a strong recommendation. Everyone should get this. Now, the evidence shows it might not directly shorten your hospital stay, but there's moderate evidence it can really cut down anxiety, especially if the info is tailored, even using things like VR.
Virtual reality to reduce anxiety before surgery. That's pretty cutting edge.
It really is. Then you get into preoperative optimization. This is a big area, 6 key parts. First, identifying high-risk patients. Strong recommendation to use predictive tools here, like the ASA status or the ACS NSQIP risk calculator.
Okay, but hang on. You said a strong recommendation, but the evidence for it directly reducing mortality or complications is very low. How does that work?
That's a really sharp question. It highlights something important about guidelines. Even if the direct evidence linking this specific tool to fewer deaths is currently limited, identifying who's high risk is absolutely vital for planning, for having the right resources ready, for informed consent. It's about being proactive, aligning with good medical practice, even while we wait for stronger outcome data on the tools themselves. Makes sense.
Yeah, okay, that clarifies it. It's about preparation. What's next in optimization?
Second, managing comorbidities. Strong recommendation, again, get things like heart disease, COPD, kidney issues, diabetes under the best possible control before surgery. Although, again, the direct evidence for this specific action reducing mortality or complications in the ERAS context is currently rated low. It's still considered best practice.
Right.
Third, alcohol cessation. Now, this is a really interesting shift from 2018. Back then, it was a strong recommendation for heavy drinkers to stop 4 weeks before. Now, it's a weak recommendation.
Weak. Why the change?
Because the evidence directly linking that 4-week cessation period to fewer surgical complications or shorter stays is actually low quality. Now, nobody's saying alcohol abuse isn't risky. It absolutely is linked to infections, lung problems, bleeding. But proving that a specific pre-surgical stop period directly prevents those specific surgical outcomes in well-controlled studies is challenging. Observational studies have bias issues.
That's a really important nuance to grasp. It's not a green light. It's about the specific proof for that intervention in this context. Wow.
Exactly. It shows how science refines things. Fourth, smoking cessation, still a strong recommendation. Quit, use behavioral support, nicotine replacement, ideally at least 4 weeks before. Here, the evidence is moderate for reducing mortality and complications. Interestingly, quitting less than 4 weeks before didn't show a difference in complications in the studies reviewed.
4 weeks seems key there.
It appears to be, yes. Fifth, prehabilitation. Another major, maybe surprising change. In 2018, weak recommendation for it now. No specific prehabilitation regimen can be recommended.
Whoa, okay. No specific regimen. That feels like a step back given how much we hear about prehab.
It's less a step back, more a reflection of the complex evidence. The studies out there are moderate to low quality, and frankly, they give conflicting results on function, complications, hospital stay. Part of the problem is everyone defines and does prehab differently. So finding consistent proof for one specific recipe, it's proven really hard. It's not saying prehab is bad, but a universally proven one-size-fits-all plan, the evidence isn't there yet.
Fascinating. So much ongoing debate there. What's the last optimization point?
Sixth, anemia treatment. Strong recommendation for routine screening and fixing anemia. Weak recommendations for using preoperative IV iron and also for high-dose EPO if anemia is severe or there's not much time. The evidence is moderate that this improves long-term survival and cuts down on transfusions. Moderate again that it doesn't necessarily change complications or length of stay. 5E iron seems better than oral. And the use of EPO, that's actually a new addition in these 2025 guidelines.
Okay, so optimization is about ticking all those boxes, getting you in the best possible shape beforehand.
Precisely. Then there's preoperative nutritional care. Strong recommendation for routine screening. Weak recommendation for supplements if someone's malnourished, including something called oral immunonutrition, specifically for colorectal cancer surgery. Evidence for screening itself is low, but moderate for supplementation. And that immunonutrition part is new, based on evidence it might reduce infections.
Immunonutrition, okay.
Next up, PONV, that's postoperative nausea and vomiting. Strong recommendation for using multiple drugs together to prevent it. Specific ones are named, like aprepitant, remocitron, dexamethasone. The evidence quality is high here, and they've refined the recommended combinations. And it matters because PONV hits over 30% of patients, really impacts recovery.
Makes sense. What about calming nerves before surgery? Sedation.
Right, pre-anesthetic sedation or anxiolytics. The recommendation is weak against routinely using them. Moderate evidence shows no real benefit for routine use, and they can cause temporary psychomotor issues. Interestingly, giving some pain relief before surgery seems to reduce later opioid need and PONV.
So basically, talking to patients, managing expectations, that might be better than just giving a sedative routinely.
That seems to be the direction, yes. Focusing on communication and education rather than just medication for anxiety, especially given potential downsides.
Got it.
Then a really big one, mechanical bowel prep, MBP. The recommendation is weak that it should not be used routinely for colon surgery, but strong recommendation to consider it for rectal surgery if they're planning a stoma, and if you use MBP, you must add oral antibiotics. The evidence is high quality against using MBP alone, and also high quality for using MBP plus oral antibiotics compared to MBP alone.
Okay, hold on. The recommendation for avoiding MBP alone went from strong in 2018 to weak now. That's another significant shift.
It is. It reflects the growing evidence for the benefit of the combination approach MBP with oral antibiotics in certain situations, particularly rectal surgery. It's moving away from a simple never do MBP to a more nuanced avoid it alone, but consider it with antibiotics in specific cases. It shows how guidelines adapt.
Fascinating. What about fasting?
Preoperative fasting and carbohydrate loading. Strong recommendation for short fasting. Clear fluids okay up to 2 hours before. Solids need 6 hours. Good evidence this improves insulin sensitivity, reduces PONV. However, the carbohydrate loading drinks, that's now only a weak recommendation.
Right, so less fasting time is good, but the special sugar drinks maybe aren't the magic bullet we thought. That changed from strong to weak, too.
Exactly. They might help insulin sensitivity a bit, but clear clinical advantages over just doing the standard short fast. The robust proof isn't quite there anymore. It's about finding what really provides measurable benefit. And just to round off the pre-op phase, antibiotic prophylaxis. Strong recommendation for IV antibiotics within 60 minutes before cutting, repeated if surgery is long or there's blood loss, and oral antibiotics strongly recommended if MBP is used. Skin prep. Chlorhexidine and alcohol-based stuff, strongly recommended. High-quality evidence for all that. And staying hydrated with clear fluids up to 2 hours before, also strongly recommended.
Okay, patient prepped, optimized as much as possible. Let's move into the operating room. What happens during the surgery itself that these guidelines flag as really key for recovery?
All right, intraoperatively. The anesthetic protocol has several strong recommendations. Use short-acting drugs. Use brain monitoring, like BIS, to guide how deep the anesthesia is. Use strategies to reduce inflammation and adrenergic response. Avoid letting blood pressure drop too low. Use protective lung ventilation strategies. And make absolutely sure muscle relaxation is fully reversed at the end. There's also a weak recommendation about using deep muscle relaxation to potentially lower pressure inside the abdomen during keyhole surgery.
Can you unpack some of that? Like why short-acting agents or the brain monitoring?
Sure. Short-acting agents allow for quicker wake-up and potentially less hangover effect. Agents like propofol might also have some anti-inflammatory benefits and cause less nausea. There's also a push away from some gases due to environmental impact. The brain monitoring, cerebral monitoring, helps tailor the dose. Too deep, you risk side effects like low blood pressure or delirium later. Too light, well, that's obviously bad too. It helps personalize it.
Makes sense. Precision anesthesia.
Exactly. Next, keeping the patient warm, normothermia. Strong recommendation for active body surface warming during the operation. The evidence is really solid here. High quality for reducing surgical site infections, moderate quality for reducing blood transfusions, and just patients feeling better afterwards.
Keeping warm seems like a no-brainer, but what's the deeper dive? Specific methods? What happens if you do get cold?
Yeah, it seems obvious, but the how matters. We're talking underbody forced air warming blankets, sometimes warmed IV fluids, or even warmed humidified gas for laparoscopic surgery. And getting cold hypothermia isn't just about shivering. It can mess with blood clotting, increase blood loss, make recovery in the PCU longer, and significantly raise the risk of infections. So preventing it is crucial.
Right. Fluids during surgery, you mentioned a shift earlier.
Yes, intraoperative fluids. There's now a weak recommendation to aim for a slightly positive fluid balance on the day of surgery, based on moderate evidence.
That's the change from near zero balance, right? Why the shift again?
It's because being too restrictive, the old zero balance idea was actually found to increase risks, particularly acute kidney injury and maybe infections. So the thinking evolved. It's about finding the sweet spot, not dehydrated, but not overloaded either, aiming to avoid excessive weight gain, like more than maybe 2.5 kilos from fluids. It's about physiological balance.
Finding the Goldilocks zone for fluids. Got it. What about the type of surgery?
Surgical approach. Minimally invasive surgery, MIS, like laparoscopy or robotics, strong recommendation. It should be the routine for colorectal cancer patients if the expertise is available. And critically, it needs to be combined with the ERAS protocols. High-quality evidence supports this.
So MIS is really standard care now, assuming the surgeon's skilled in it.
Pretty much, yes. The recovery benefits are well established. Although it's interesting, the guidelines do point out that while robotic surgery use is increasing, there isn't strong evidence yet that it's definitively better than standard laparoscopy, especially given the higher costs.
Cost effectiveness is always a factor. Okay, last thing in the OR, drains.
Abdominal drainage. Strong recommendation against routine drains after colon resection. Weak recommendation against routine drains after rectal resection.
So drains aren't automatically helpful. That might surprise some people.
It can seem counterintuitive, yeah. But the evidence suggests they don't reliably prevent leaks or infections, and sometimes they might actually increase surgical site infections or keep people in hospital longer. So unless there's a specific reason, the default is not to use them routinely.
Okay, surgery's done. Now the recovery phase begins. What are the key things post-op according to these guidelines?
Right, postoperative phase. First, nasogastric tubes and GTs. Strong recommendation not to leave one in prophylactically after surgery. Moderate evidence supports this. Now, if the patient is vomiting, then yes, put one back in. But routine use just in case. No. Interestingly, the evidence quality for not using them dropped from high to moderate since 2018.
Slight shift in confidence there. What about blood sugar?
Normoglycemia. Strong recommendation to avoid both high and low blood sugar during and after surgery. The target range post-op is about 140 to 180 milligrams per deciliter. If someone had a high HbA1c before surgery, there's a weak recommendation to check their blood sugar 6 times a day afterwards. The idea isn't super tight control, because that risks hypoglycemia. It's about keeping it in a safe, reasonable range for healing.
Okay. And fluids after surgery, does that slightly positive balance idea continue?
It does. Strong recommendation to maintain that slightly positive balance, keeping weight gain under 2.5 kilos. Weak recommendations to use balanced crystalloid solutions for maintenance fluids and to avoid using standard 0.9% saline, normal saline, for replacing losses. Again, it's about that balanced approach.
Urinary catheters. Get them out quick.
That's the theme. Strong recommendation. Out within 24 hours for straightforward keyhole colon surgeries. Weak recommendation. Maybe within 48 hours for straightforward keyhole rectal surgeries. If an epidural is in place for pain relief, weak recommendation to wait until after day 2.
Seems like they really want that catheter gone ASAP.
Definitely. The longer it's in, the higher the risk of infection, and it stops people getting up and moving. Things like being male, older age, having rectal surgery, or an epidural can make retention more likely, but the guidelines specifically say don't use alpha agonist drugs to try and prevent it.
Right. What about preventing the bowel from slowing down? Ileus.
Yes, postoperative ileus. Strong recommendation for a multimodal approach using lots of different strategies together to minimize it. High evidence for the combined approach. Moderate evidence supports many specific things. Early feeding, certain pain relief like epidurals and open surgery, probiotics, specific drugs like prucalopride, and chewing gum.
Chewing gum, seriously, and it's back after being dropped.
It is. The evidence came back supporting it. Seems simple, but chewing gum can apparently stimulate the gut, potentially reduce ileus duration, help get things moving faster, a low-cost part of the overall plan.
That's brilliant. Okay, pain relief after surgery.
Postoperative analgesia. Strong recommendation again for a multimodal strategy. Base it on acetaminophen, maybe add tap blocks for abdominal wall numbness, NSAIDs for colon surgery, sometimes intrathecal morphine given during the spinal anesthetic. Importantly, thoracic epidural analgesia, TEA. Strong recommendation not to use it routinely in MIS, keyhole surgery. It's weakly considered as an option for open surgery. The goal is good pain control without relying heavily on opioids, which have side effects like constipation and drowsiness, hindering recovery. So lots of non-opioid options are key.
Makes sense. And nutrition after surgery.
Postoperative nutritional care. Crucial. Strong recommendation. Start feeding the gut early within 24 hours. Resume normal food as tolerated. Monitor how much the patient is actually eating daily. Strong recommendation for oral nutritional supplements, ONS, for malnourished patients even after they go home. Weak recommendations for using ONS alongside normal food for the first 3 to 5 days in hospital, and maybe using immunonutrition for up to 7 days post-op.
So it's not just what you eat, but getting started early is really emphasized.
Absolutely. Early feeding gets the gut working, improves nutrition, potentially shortens the hospital stay. It's a cornerstone. Finally, mobilization. Getting up and moving. Strong recommendation. Start ideally on the day of surgery. And another strong recommendation, aim for mobilizing at least 3 hours per day from the first day after surgery until discharge.
3 hours a day, that sounds like quite a bit, but wasn't it even more, like 6 hours?
It was. The 2018 guidelines recommended 6 hours. This has been revised.
Okay, wow. That was a comprehensive run-through. So we've really covered the whole journey, guided by these new 2025 ERAS guidelines. We've seen this incredibly detailed, evidence-focused approach. And some really key changes, the shifts on alcohol, prehab, the nuances of fluid balance, even chewing gum making a comeback. It really paints a picture of constant refinement, trying to optimize every single step for patient recovery using this big multimodal strategy.
Absolutely. And if you zoom out, connected to the bigger picture, what it really highlights is just how dynamic medicine is. Seeing recommendations shift from strong to weak or even no recommendation. It doesn't mean the old way was wrong. It just means our understanding, based on the best available evidence right now, has evolved. It really underlines how important it is to keep questioning, keep researching, critically assessing the evidence, even when it seems complex or maybe contradictory, to continuously find the best ways to care for patients.
So for you listening, after this deep dive into the absolute latest in surgical recovery, what stands out? Maybe think about how this detailed understanding might change how you approach conversations about your own health, or maybe the care of someone you know. Because this isn't just about colorectal surgery, is it? It's about this relentless drive in medicine to get better outcomes, fueled by nonstop learning and adapting. Definitely something to keep that curiosity alive.